What is population health? At Mount Sinai, population health means we take responsibility for the health outcomes of our patients and use resources wisely. By investing in new care models and technologies and embracing a person-centered approach to care, we partner with patients, families, community organizations, and health insurers to improve the health of groups of people for whom we are accountable. Members of Mount Sinai and our community partners must engage as a team to achieve population health goals. These goals include simultaneously improving health outcomes, the patient experience, and reducing the overall cost of care, as well as engaging and supporting our providers and all members of our workforce. Population health shifts from paying for the volume of services to paying for value of those services. When patients are sick, they seek care from healthcare providers. The traditional model for paying providers is called fee-for-service. Under that model, providers are incentivized to treat as many patients and provide as many services as possible. Payment for these services is tied to the service and not the health outcome. Additionally, there is no payment to providers for work done on behalf of a patient's health that falls outside the existing billing structure, such as when a provider spends extra time tailoring a patient's care plan to make sure they feel empowered and understood. Because of this payment structure, costs increase without always improving a patient's health. Let's meet Joe, a Spanish-speaking father of two who works at a supermarket who lives in New York City. Joe has a number of barriers in the way of improving his health. He struggles with diabetes and hypertension. Moreover, he is battling depression and anxiety, which are exacerbated by these medical conditions and the stress of his job. Over the past few years, Joe has had multiple visits to the emergency department as well as hospitalizations for his uncontrolled diabetes. Joe struggles with incorporating healthy food into his diet as a result of the options in his neighborhood. The instructions that he receives about his health care are typically only in English, which is not his preferred language. Access to timely care is difficult for Joe, as it's both hard for him to get appointments with his doctors and he has limited transportation options. Today, after lunch, Joe begins to feel dizzy, lightheaded, and confused. He checks his blood sugar, and as much as he dislikes calling 911, he realizes he needs immediate attention for this emergency. He can't believe it's happening again and that he has to leave work. It's the second time this month. In the emergency room, his needs are triaged and evaluated. Joe is sent to an observation unit to help stabilize his condition and be observed until it's safe for him to be discharged. Once the physician authorizes Joe's discharge, the nurse proceeds with the discharge process. He hands Joe his paperwork with instructions to follow up with his primary care provider, otherwise known as his PCP. The next day, Joe calls his PCP to schedule his follow-up and makes an appointment for the following week. He then tells his supervisor he will need to take a personal day. 1 week later, there are bus delays on the day of his appointment, and Joe arrives later than scheduled. He misses his appointment, and the PCP has to find time for him as an add-on patient. After 2 hours in the waiting room, Joe is frustrated, but he finally gets to see his PCP. The PCP listens to Joe's story and requests the discharge summary, which he forgot to bring. In thinking about Joe's case, given his complexity and how many times he's been in care over the past few months, she decides it's time for Joe to see a specialist. She suggests Joe sees an endocrinologist. She gives Joe a number to call and tells Joe to come back to the office after he has seen the specialist. Feeling tired but on good faith, Joe reaches out to the specialist and cannot get an appointment for a number of weeks. Within 2 weeks, Joe's condition deteriorates, forcing him to end up not only back in the ER, but admitted to the hospital. He ended up having to spend more than 3 days in the hospital, making him miss work and raising both his and his providers' costs. Many factors contributed to Joe's experience, some related to clinical conditions, some to his social environment, and others to his lack of access. The result? He did not get timely, quality care, leading to worse health outcomes. His treatment was also substantially more expensive than it needed to be because of his frequent readmissions to the hospital. This experience was both bad for Joe and bad for healthcare spending. In relation to other high-income countries, the United States spends far more on healthcare. Over the past 3 decades, spending levels continuously rose and healthcare outcomes diminished. Among the 11 countries included in a recent Commonwealth Fund study, the United States ranked last in healthcare system performance. What's important to note is that New York, in particular, is struggling. As projected by the Centers for Medicare and Medicaid Services, CMS, New York's healthcare costs are expected to rise by 53% by the end of 2020. This care delivery system leads to redundancies, inconsistent outcomes, and poor transitions of care regardless of the good intentions and extra effort put in by individual health professionals. The result? Higher costs and lower quality of patient care. Over the past 10 years, there has been an increasing focus on both the public and private sector on value-based care, which embraces the Institute for Healthcare Improvement's Triple Aim. The Triple Aim provides a framework for optimizing health system performance by simultaneously focusing on the health of a population, the experience of care for individuals within that population, and the per capita cost of providing that care. Many private commercial health insurers and provider organizations are partnering to shift incentives away from fee-for-service towards value-based payments. As a result of these trends, federal and state governments are looking for a way to encourage and support population health transformation across the industry. For example, in 2015, Congress passed the Medicare and CHIP Reauthorization Act, or MACRA, with overwhelming bipartisan support. MACRA codifies a timeline and structure by which CMS, as the largest health insurer in the country, would shift payments to providers from volume-based to value-based over the coming years. In that same year, New York State implemented DSRIP, the Delivery System Reform Incentive Payment Program, as a local catalyst to move the state towards achieving the Triple Aim and transition to value-based care. DSRIP's goals include integrating delivery of clinical care to address community needs and improve the health of identified populations, a shift to value-based payment arrangements that reward providers for quality rather than fee-for-service, reducing avoidable hospitalization by 25%. While fee-for-service will continue to have a place in our system, adopting value-based payments more broadly incentivizes quality care rather than the number of specific services provided. This corresponds to the Triple Aim's goal to reduce per capita costs. This value-based system rewards providers for promoting wellness and offers additional funding to make system-wide improvements in workflow and technology. These changes and investments make it easier for health professionals to work together as a team, employ evidence-based practices, and focus on preventative care, improving the overall quality of care provided by our system. In order to improve the experience of care, health professionals work together in a patient-centered model. By keeping our patients' individual needs and cultural background in mind, we are able to provide them with a better patient experience. Hard work alone cannot be our only solution. Our system must change through the adoption of the Triple Aim and a population health approach. Together, we will become better stewards of health resources for the patients and communities we serve. Remember Joe? Let's see what his experience looks like now in this value-based approach called population health. Let's meet Joe again once he is stable and waiting to be discharged from the ED observation unit. This time, the nurse hands him his paperwork with a Spanish translation. He explains to Joe why it is important to follow up with his PCP and offers to help make the appointment. Thankful to have the help, Joe takes him up on the offer and leaves with an appointment for the next day. At the same time, Joe's PCP receives a notification about the ED visit and tells her team that they need to talk about Joe in the morning before his visit. The next morning, the care team pulls information about Joe's ED visit from a health information exchange, meets to discuss Joe's case, and starts to draft a care plan that the PCP will later get Joe's feedback on. The PCP also realizes she could use a specialist's consultation on Joe's medication and reaches out through an e-consult platform. This enables her to change his medication without sending him for yet another appointment. On the day of his appointment, there are bus delays, and Joe arrives later than scheduled. However, since the care team was expecting him and already aware of what had happened, they were able to make time for him. After being stuck on the bus, Joe is glad he can be seen by the PCP without too much delay. The PCP meets with Joe and discusses the ED visit. She shares important information, including his new medication, asks him what he thinks about the proposed care plan. He agrees with the plan, but tells her that he's feeling depressed and anxious lately and is wondering if they could include that kind of support in his care plan. The PCP thanks him for bringing this up, and they discuss the importance of why changes are needed to improve his health. She connects him to a certified diabetes educator who discusses nutritional options with Joe that take into account what's available in his neighborhood and aligned to his cultural preferences. The PCP also introduces Joe to a care coordinator to support him with finding resources in his community and helping him navigate the healthcare system so that in the future, 911 does not have to be his only option. This time, Joe is not alone. By following his care plan and receiving regular support from his entire care team, Joe's overall health has improved after only a few months. His follow-up blood work exams show improvement in his A1C level. He was able to select the community services that best met his needs for managing his depression, anxiety, and adherence to medications. With diet and exercise, he is able to reduce his weight. Joe is healthier and happier. What does this mean for you? You are part of a patient's care team in this new coordinated approach. Your network has expanded across New York and is becoming more integrated. While these changes will look different depending on where you work, your access to tools make providing care to your patients easier, more efficient, and an all-around better experience. Transformation is not easy. Joe's journey is only one example in a city of more than 8 million people and a state of more than 19 million. Your contribution as a healthcare professional matters. It's going to take a collective effort within this network to adapt to new models of care and technology as part of an evolving workforce. Together, we can provide better health outcomes, lowered costs, and more efficient delivery of services for patients like Joe. Thank you for viewing this video.